All right, so still talking about how every cell needs oxygen to survive, just like I was saying earlier. So we have 0 to 1 minute, you're going to have cardiac irritability. You might start seeing ischemia. 0 to 4 minutes, brain damage, not likely. However, 4 to 6, brain damage is possible at this point. The cells are not oxygenated enough to get that O2 to the brain. 6 to 10 minutes, brain damage, highly likely. And then once you're beyond 10, irreversible damage is happening at this point. Hypoxia, dangerous condition in which tissues and cells do not receive enough oxygen. Death may occur quickly if not corrected. Varying signs and symptoms. You have onset and degree tissue damage. Often depends on the quality of ventilation. It's like I was talking about earlier, you want to make sure that the chest is getting equal tidal volume, equal chest rise and fall to determine your ventilation. Early signs include restlessness, irritability, apprehension, tachycardia, and anxiety. Late signs include mental status, changes in weak, thready pulse, cyanosis. Responsive patients often report shortness of breath, dyspnea, Nia is breath, I believe. May not be able to speak in complete sentences. So it is best to administer oxygen before signs and symptoms appear. Ventilation perfusion mismatch. We have lungs that have a role in placing ambient air to circulating blood to permit gas exchange. This is our ventilation or inspiration. Yes, inspiration. Air and blood flow must be directed to the same place at the same time. Ventilation and perfusion must be matched. Failure to match ventilation and perfusion, your VQ mismatch, lies behind most abnormalities in oxygen and carbon dioxide exchange. In most people, normal resting minute ventilation is approximately 6 liters per minute. So per minute, you are breathing 6 liters of air that is being exchanged. Pulmonary artery blood flow is approximately 5 liters per minute. So your heart is pumping approximately 5 liters of blood through itself per minute. Overall ratio of ventilation perfusion, 4 to 5 liters per minute or 0.8 liters per minute. That is your VQ match. You have, because neither ventilation or perfusion is distributed equally, both are distributed dependent regions of the lungs at rest. However, an increase in gravity-dependent flow is more marked with perfusion than ventilation. When ventilation is compromised, you're going to have, but perfusion continues, blood is going to pass over the alveolar membrane without gas exchange. Lack of oxygen diffusing the circulatory systems. Carbon dioxide is recirculated into the bloodstream, which results in a VQ mismatch. Could lead to severe hypoxemia. Could also, if not recognized and treated, and then similar problems can occur when perfusion across the alveolar membrane are disrupted. So less oxygen is absorbed into the bloodstream, less carbon dioxide is removed, VQ mismatch. Could lead to hypoxemia. Immediate intervention is needed to prevent further damage or death. So not only do you have to circulate and breathe, but you have to circulate and breathe at the right VQ match. Factors affecting ventilation. So we are maintaining a patent airway, make sure it's open, there's no stake, and critical for provision of oxygen tissues. Intrinsic, this is your internal, and extrinsic, external factors that cause airway obstruction. So we have intrinsic factors that include infection, allergic reactions, unresponsiveness, and the tongue is most commonly an obstruction that is going to obstruction in an unresponsive patient. Your tongue can fall in. That's why we have the OPAs and the NPAs. NPAs are in the nose, OPAs grab the tongue to make sure it doesn't fall and close the opening. However, if you stick that in whenever they have a gag reflex, you're going to get vomit on you. And yeah, my captain made sure that it's different when you're out in the field versus medic school, because this is cookbook medic, like rinse and repeat, do this, go down the line, check the box, go down the line, check the box. Then you go out in the street and you try to go and check the box and it's like, what the F are you doing right now? You're not like, this is going to happen. This person's going to throw up all over you. And you're like, oh yeah, common sense, I would do that. But I'm just so monkey trained to do X, Y, and Z, which is the difference of you take the skills that you learn and then you apply them to which they would apply in real life. And that just takes time. That is the difference in experience versus just knowledge. Some factors that are not necessarily a direct part of the respiratory system, you have interruptions to the central and peripheral systems that can drastically affect breathing. We have medication that depress the central nervous system. If taken in excess, lower the respiratory rate and reduce tidal volume. So we have carbon dioxide in the respiratory system, and the circulatory system is going to increase, which then increases carbon dioxide in the blood. If it's in the circulatory system, increases in the blood. Trauma to the head and spinal cord can interrupt nervous control of ventilation. Neuromuscular disorders can affect the nervous system control of breathing. Examples, we have muscular dystrophy, polymyelitis. All right, that's a word that would be really good. So off the top, I know itis is going to be inflammation. I know meis is like Greek for muscles, and like they call it that because it's like it looks like a mouse. So like measle, something. Polio though, I'm not sure what polio is. Neuromuscular blocking agents and paralytics. Paralyze a patient and introduce apnea. Not doing something, apnea, breathing, breath. Paralytics, neuromuscular blocking agents, paralytics, paralyze the patient and induce apnea, which is why we have to breathe for them whenever we RSI, rapid sequence induction the patient for intubation. Allergic reaction. Let's throw Spanish in here too. If you're in town and country and you got to speak to the Spanish population, allergies. Alergia. So, tú tienes alergia. You can talk to them, but you also have to know what they're going to say back, and they're probably going to talk very rapido right back at you. So that makes it a little complicated, but the more you practice and play, the more you're going to learn. Swelling, angioedema. Okay, so this can also obstruct the airway. This is, well, let's see what it says. Bronchoconstriction, decreased pulmonary ventilation, also associated with conditions such as COPD and asthma. And I just want to double check that I'm recording. All right, good. Associated with conditions like COPD and asthma. Angioedema, large edema, circles, red circles, almost like hives, but like put 5 hives together and you get a pretty much circular edema happening. So that can obstruct the airway. Someone had that 2 days ago, actually. What did we give her? Loratadine? I think it was Loratadine. Antihistamine, 10 milligrams for 24 hours. Extrinsic factor, and that's over the counter. Extrinsic factors can include trauma and foreign body airway obstruction. So trauma to the airway or the chest require immediate evaluation and intervention. Blunt and penetrating trauma and burns, so this can disrupt airflow through the trachea and into the lungs. Quickly results in oxygenation deficiencies. Trauma to the chest wall can result in structural damage to the thorax, leading to inadequate pulmonary ventilation. Example, a patient with numerous fib fractures or flail chests could purposely or shallowly, in an attempt to alleviate pain from the injury, breathe shallowly to prevent pain. Call respiratory splinting. Okay, this was a test question. I should actually put this in here. Can result in decreased pulmonary ventilation. Proper ventilatory support is crucial. So what I put, you put a sandbag on the chest, and honestly, I read that somewhere, I saw that somewhere. I think that's the right answer, but I should put that in, as soon as I'm done with this video, I'm gonna put that in the test question bank I have. Hypoventilation occurs when carbon dioxide production exceeds carbon dioxide elimination. Carbon dioxide production can exceed the body's ability to eliminate it. Carbon dioxide elimination can be depressed to the extent that it no longer keeps up with normal metabolism. Hyperventilation occurs when carbon dioxide elimination exceeds carbon dioxide production. Hypoventilation and hyperventilation could represent the body's attempt to compensate for various abnormal conditions, which I hope we get into. Here we go. For example, if the pH of the blood is too high, Alkalosis over 7.45, I believe you start having seizures or so, so the body is going to try to get rid of carbon dioxide. pH of the blood is too high, the patient breathing may become slow or shallow. Okay, so slow or shallow, they are hypoventilating, an attempt to retain carbon dioxide to decrease the pH. Okay, so the pH is too high, metabolic. Okay, it says the blood is, I don't know if that's metabolic or not, but the blood is too high. So we're going to keep the carbon dioxide, so we don't want to breathe as hard. We're going to go into hypoventilation. So that way the blood can retain carbon dioxide and become more acidic, lower from 7.45 to maybe 7.35. Decreased in minute volume decreases carbon dioxide elimination. Result, buildup of carbon dioxide in the blood. This is called hypercarbia. Increased in the minute volume increases carbon dioxide elimination, lowers carbon dioxide in the blood. Hypocarbia. Hypercarbia, hypocarbia. Okay, so if they're hypoventilating, minute volume goes down and CO2 elimination goes down. They're not breathing deep, they're breathing shallow, and they are breathing slow. And then the opposite, if we're CO2, we're trying to get it out of there, and minute volume is also going up as well. Hypercapnia, hypocapnia, PaCO2. I don't know if that's capnography. Hypercapnia. So we're going to see higher capnia. Okay, partial pressure of carbon dioxide. PaCO2, partial pressure of carbon dioxide. We'll stop there.